All right, so the bowel ultrasonography. This is just an overview, this particular slide over here, which we have the small and large intestine. So we are going to talk about these structures, the small and the large intestine. Now, if we check this, we are seeing the large intestine over here. Then we have the small intestine in the center. So let's start from the stomach. Let's start from the stomach. This is the stomach. When you eat and the food gets here in the stomach, the food undergoes something we call churning. The food churns. And once you eat, there will be acid production. So that acid is hydrochloric acid, and the pH is from 2 to 4 strength. And that acid in the stomach, when it is poured on your skin, it will wear your skin off, but it is still in the stomach. That is why the food that we eat, we are not always getting sick, because every food we eat contains microorganisms that the acid kills it. It's not there to kill the microorganisms alone, but it's also there to make sure that the foods that we eat, that we don't even chew it well, they will be well broken down and become very soft. Also, when the acid is produced in response to food in the gastric mucosa, that acid is going to activate a certain enzyme called pepsinogen. Pepsinogen, when it is activated, then we will have pepsin and renin. And pepsin is responsible for, pepsin and renin, they are responsible for protein digestion. But pepsin is for the meat, the egg, the peas, and the rest. And then the renin is for milk coagulation and digestion. Now, when the food becomes soft and the stomach is done with its breaking down, the food will be pushed into the duodenum. But before it will get to the duodenum, the pylorus, having a pyloric sphincter, has to open. It is a sphincter. It regulates the in and out. Let me say the inflow, because the food doesn't have to come back. It regulates the inflow of food into the duodenum. So it will open, the pylorus will open, and the food will come to the duodenum, first part of the duodenum, second part of the duodenum, and the third part of the duodenum. Then the food will get to the, but when it gets to the duodenum and it contains fat, even if it doesn't contain fat, the pancreatic juices, or from the pancreas, the juices will be added. The pancreas will produce its juices and it will be added on the food. And then there will be trypsin to also make sure that the rest of the proteins and carbohydrates also start to be broken down for further digestion. And we also have food that contains fat. For the fat, the duodenum contains some cells, enterocytes, and those cells are going to sense the fat and also cause the system to produce cholecystokinin. It's a hormone, and that hormone will go to the gallbladder and ask the gallbladder to contract and relax continuously, so that bowel pigment will be secreted onto the food to emulsify the fat, so that fat will be able to break down. That's why when you eat fatty foods, it stays in your system for long, because fatty foods don't start their digestion from the mouth nor the stomach. They start their digestion in the duodenum. But carbohydrates start their digestion in the mouth. and then continues in the duodenum. Proteins start their digestion in the stomach and continue the digestion in the duodenum. But fats alone start the digestion in the duodenum. So it will take a long time before the food will get to the duodenum, before digestion will start. By that time, carbohydrates has few hours to finish. So that is it. From the duodenum, the food will move to what? The jejunum. The jejunum. And the jejunum has villi that will make sure that the food, the digested food will be what? Absorbed into the system through the portal vein to the liver. Now, the food that fails to be absorbed here will move to the ileum. Will move to the ileum, this part of the ileum. And the ileum too has a lot of the villi cells that will cause the rest of the food to also be absorbed. Now, if the food gets to the terminal ileum over here and it has still not been absorbed, then it means that it is undigested. So the food will get to the cecum, this place. The cecum is the large intestine. So before it will get to the cecum, we have something called ileocecal junction. Ileum and cecum, you understand? That's the junction where the ileum discharges its content into the cecum, which is large intestine. Now, this whole thing from this place coming up is called ascending colon, because the large intestine is moving up, ascending colon. But the tip of it here is called the cecum. Now, terminal end of the cecum, we can see a tubular structure called the appendix over here. We are going to talk about this appendix. It's a very important structure, this appendix. So it is connected to the cecum at the terminal end. Now, the cecum will move up, and as it is moving up, we call it ascending colon. Where it is curving over here, the liver is around this place. You see, the liver is here. So we can call it hepatic flexure or right colic flexure, right colic colon, flexure. When it flexes, it forms the transverse colon. Because this transverse colon is what? Curving, is dividing the abdomen. It is having a cross section of the abdomen. So it is transverse colon. Then when the transverse colon is curving, we call it left splenic flexure, or we call it splenic flexure. Some people call it left colic flexure because the spleen is also around this place, the spleen. So splenic flexure or left colic flexure. When it curves like that, it forms the descending colon. The descending colon. Now the descending colon gets here and also curves to form the sigmoid colon, because they are coming down, so descending. A curve, sigmoid. And lastly, we have the rectum over here, where the feces will be stored. But the food passing through the ascending colon, transverse colon, and the descending colon, don't forget, water content in the food will be drained. Vitamins will be drained. Folic acid and the rest, they are all vitamins. They will be drained into the system. That's why when you keep undigested food in your system for too long, without going to toilet, you may get headaches and the rest, because the water content in it, they are not that hygienic, and if you don't go to toilet, they will be drained into your system. This is the rectum, where feces will be stored, and we have the sphincter, anal sphincter over there, and we have the anus continuous. So this is basically the bowels, but we started from the stomach. You understand? Okay. Let's move on. So you can see the ileocecal junction very well. Where this ileum, the ileum is discharging its contents into the cecum, ileocecal. So you can see a valve over here. The valve is there to prevent backflow of the food, the undigested food from the cecum back to the ileum. No. Look at the tip of the valve. It will prevent backflow. But forward flow is possible. So always there is forward flow, but not back flow. That is from the ileocecal valve. The appendix is there, and then yes, the round structures that make up the bowel. We call it the hastrum or the hostrum. So I think I've talked about the rest. Now the appendix. The appendix or vermiform appendix. You see, we call it vermiform because verm is a worm. Verm, I think in Latin or Greek, it is a worm. So vermiform appendix is like a worm, and it's a muscular structure attached to the large intestine in the human body. Muscular structure attached to the large intestine in the human body. One theory is that the appendix acts as a storehouse for good bacteria, rebooting the digestive system after diarrheal illnesses. Other experts believe that the appendix is just a useless remnant from our evolutionary past. You see, the appendix, for me in particular, though some medical journals are saying that the appendix is useless, but for the researches that we have been doing all the time too, most articles are saying the appendix harbors or contains a lot of normal flora. We call something normal flora. They are the normal bacteria in our system. Nature puts the normal bacteria there because most of them are in the colon, and they make sure that the undigested food, they try to break some of them down to give vitamins and the rest. Something like beans. It is the normal flora that will break the beans down, the undigested part of it down, and the byproduct will be gas. That's why when you eat beans and egg and the rest, you may be fattening more frequent. And it is from the normal flora. They are there, they are helpful for us. Though they are bacteria, but they are helpful. That is, nature put them at a place that they can't harm you. But they can tend to be opportunistic bacteria. When you do something or when something happens and they move from where they are to a different site. When they move from where they are, from their comfort zone to a different place, they will become harmful. So the normal flora are normal bacteria, and we are saying that they are in the colon. Now, what if you get diarrhea? What happens? When you get diarrhea, you will be running, you will be going to the toilet more frequently. And what happens? It will wash about 70% of this normal flora away. Where do you think we should get the normal flora back? So some articles are saying that the normal flora will be replaced by the appendix because the appendix harbors them over there. So when you get diarrhea and you lose about 80% of the normal flora, the appendix will be prompted that we need normal flora in the colon. So the appendix will just push some into the colon so that they will come and replenish them. They will come and replace those who have been moved out of the system, and the system will go on for you. So that is the good bacteria. But you see, the good bacteria can turn opportunistic. That is why ladies have always been told that when you are cleaning, when you are done with your toilet and then you are cleaning yourself, it should be from what? Front to back, not back to front. Because if you clean from back to front and some of the feces get in contact with your vaginal canal or something, the normal flora, they are there. Klebsiella, even E. coli in the colon, when it gets in contact with your vaginal mucosa, then it will be catastrophic. Because they have to stay in their comfort zone. They don't have to go to any other place. Sometimes some people can take antibiotics continuously. The doctor has written 7 days. The person finished with it and went to the pharmacy and bought it on himself or herself. You see, when you do this, don't forget that the normal flora, they are bacteria. So when you take it continuously, it will kill the normal flora. It will kill them. And you found one thing, you start to have issues. Especially the ladies, when you take antibiotics for too long, definitely it is going to kill the normal flora in the vaginal canal. There are normal flora there in the vaginal canal. There are normal flora in the respiratory system, normal flora in the urinary system. We have them distributed. But when they move out of that site to a different site, they will become harmful to you. So you keep on taking antibiotics, it will kill the normal flora in the vaginal cavity. And then you see that you start to have infections because they are there to control the growth. They are there to control the growth of something like candida. But you have killed them. So how can they control the candida? They can't. They can't work on some substances to produce acid to control the candida because you have killed them with the antibiotics. You understand? So that is the appendix. But when you put all this aside, some experts are also saying that the appendix is just it's just useless remnant because human being were evolution or evolutionized, and so the appendix was something else, and it is shrinking or it has shrunken, and we don't use it. It's not needed. So the appendix, when you go to the foreign countries, some of them can just go to the hospital and tell them that I want to remove my appendix. They do surgery and take it off. They don't want the appendix to get inflamed, and then they will be found wanting. The appendix can just be off, and you will still live your life. You understand? All right. Now, the appendix. The appendix can vary in length from less than 1 centimeter to greater than 30 centimeters, based on the individual. Most appendices are 6 to 9 centimeters long. That is the average. This is the appendix. Now, look at the appendix very well. Look at where it is located. Look at this muscle, obturator internus muscle. We will talk about it later. Obturator internus muscle. You can see that the appendix lies on it. And you can see the ischial tuberosity is a bone over the inflamed appendix. It's lying on the obturator internus muscle. Then the cecum is where the appendix is what? Coming from. So we will talk about the obturator internus muscle, an examination that you do with the obturator internus to find out appendicitis. Okay, McBurney's point. When we say McBurney's point, as you are lying or sitting or standing, you can check from your umbilicus, your navel, your navel. Draw an imaginary line from your umbilicus to your anterior superior iliac spine, ASIS. Here, you see, when you are standing and you want to hold your waist, where your hands are relaxing, when you are holding your waist, that part is called the anterior superior iliac spine. That part is called the anterior superior iliac spine. So if you draw a line from the umbilicus, which is the navel, straight to your ASIS on the right side, but we have the left ASIS. And from the umbilicus to the anterior superior iliac spine, 2/3 of that line, 2/3 of the length, where the 2/3 ends, like when you divide the line into 3, the 2/3, where it ends over here, the 2/3 from the umbilicus to the ASIS, where the 2/3 will end is called the McBurney's point. But when you are coming from the ASIS to the umbilicus, it is 1/3 of that line. 1/3 of that line. We call it McBurney's point. And it is at the McBurney's point that when you are You want to capture the appendix, you will stand. Have you seen the various positions of the appendix? The appendix can be here. 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 You understand? They are all various positions of the appendix. But when you stand at the McBurney's point, you will see the appendix, but not all the appendices, please, because ultrasound cannot see all appendices. So don't let any doctor or anybody intimidate you that why didn't you see the appendix. We have the appendices that you can see with ultrasound, but some of them you need CT scan. Now, when even the doctors are cutting, doing their surgery, they cut at the McBurney's point. These are the various positions of the appendix. Look, when you see the dotted lines, it means that this cecum, the cecum is lying over the appendix. When you see the dotted lines, it means something is lying over the appendix. Now let's see. We have retrocecal appendix. The retrocecal means the retro is behind. Retrocecal means that cecal, cecum, retro, behind. So the appendix is lying behind the cecum and you cannot see. Because once the cecum is lying on the appendix, you cannot see on ultrasound unless your machine is very powerful. Even that one will suffer. You have to press and press, but don't forget appendicitis is painful. If you press it too much, it's a problem. You understand? So when the cecum is lying on the appendix, you can't see it. It's retrocecal appendix. Now, let's check the subcecal. Subcecal is also, you see the appendix is below the cecum, below subcecal, below. Part of it is below the cecum, part of it is not. So the dotted lines means that it is below the cecum. The cecum is lying, it is under the cecum. The cecum is lying on it, but this place is below it. It is not lying on it, but it's just below it. Ultrasound can see the pelvic appendix very well because nothing is lying over it. Pelvic appendix. Also, we have this, which is the pre-ileal appendix. It comes before the ileum. It comes before the ileum. So it lies on the ileum, and ultrasound can also see this. But with the post-ileal also means that it comes after. So it means that the cecum, part of the cecum is lying on it, but then the appendix is to the superior part. So part is under the cecum, part is bare and free. Now, look at this, the incidence. The retrocecal that the ultrasound cannot see forms about 63% of all appendices in all human race. All human race, the retrocecal appendix, 63%. All human race, 63% of human beings have retrocecal appendix. And ultrasound finds it difficult to see this appendix. Subcecal, ultrasound can see this part, which is below the cecum, and it is not covered. That is only 2% of people. So you can have even 100 people, and you have only 2 having subcecal. So they are not common. The pelvic appendix, ultrasound can see it. That is 33%. 33% of all appendices in the world. Post-ileal is 1%, pre-ileal is 1%. So please, we are talking about the retrocecal and the pelvic appendix. A retrocecal ultrasound cannot see. Pelvic appendix ultrasound can see. So the bottom line is that not all appendices that can be seen by ultrasound. Sometimes you need to use your discretion, physical examination and history to confirm appendicitis, not ultrasound. Ultrasound is just to help. Acute appendicitis. So you can see this image. The appendix is inflamed. The appendix is inflamed, reddened. Acute appendicitis is inflammation of the vermiform appendix. It is a very common condition in general radiology practice and is one of the main reasons for abdominal surgery in young patients. CT scan is the most sensitive modality to detect appendicitis. You understand? We are saying that It is common condition in general imaging radiology, and is the main reason, one of the main reasons for abdominal surgeries in young people. So young people almost always get appendicitis because we like food. We like food. Young people, we like food, and when we put food aside, we are all we are active. We are active. We get infections because of what? Promiscuities and the rest. So all these things, they are there to make sure that the appendicitis what comes up. Now we will talk about etiologies. Don't worry, the causes. This condition is a common and urgent surgical illness with significant morbidity, which increases with diagnostic delay. We are saying that it is very common, and when there is appendicitis, it is very urgent that the person needs admission at the health facility. The person needs admission. Now, some appendicitis cases, you can just give broad spectrum antibiotics and it will resolve on its own. Some of them, whatever you do, you need surgery or else it will rupture. When you delay to diagnose appendicitis and it ruptures, the person may die. The person may die. But it's not like the moment it ruptures, the person dies. No. When it ruptures, the person will bleed from the ruptured site into the peritoneum. The blood will come down. Aside that, the suppurative content in the appendix, we just said that it contains normal flora, a lot of bacteria. All those bacteria will be released into the peritoneum and they will start to cause severe infections in the peritoneum. That may cause the septicemias, severe peritonitis, and also anemia from the bleeding, and that person may pass out. So we don't delay diagnosing appendicitis. It's very important. The lifetime rate of appendectomy is 12% for men and 25% for women. Listen, we are saying that, you see, appendectomy is the surgical removal of the appendix. We also call it appendicectomy. Appendicectomy is the same, but we prefer the appendectomy. Now, we are saying 12% for men and 25% for women. However, men will like mostly get appendicitis. But the reason why women is having 25% here is that women have other structures like fallopian tubes, like the ovaries. Women get pregnant, and so sometimes it is just ectopic pregnant, because ectopic will give all clinical features of ectopic. It's like appendicitis, ectopic. So if you are a sonographer and you are not that experienced, and you don't know that as a sonographer, you should have a urinary pregnancy test kit or pregnancy test kit at your end. That when a lady comes with severe low abdominal pain, tenderness, and you do pregnancy test before you think of any other thing. Then you always think of appendicitis. You go and write appendicitis. Meanwhile, it is ruptured ectopic or it is ectopic, and you go and write appendicitis. Then they go and session this person and find out that it is ectopic. So mostly it is misdiagnosis. So this is because of the percentages of misdiagnosed cases of appendicitis significantly higher among women than among men. Because when someone comes with severe low abdominal pain, please, and the person is a lady, it can even be ovarian torsion. The ovaries can twist. They are emergencies. They are like appendicitis. So please, for you to differentiate ectopic from appendicitis, you need to have an UPT done, urinary pregnancy test done at your end. Don't say my place is just a diagnostic center, so I don't have the test kit or something. Please buy it yourself. Use your money to buy it for accuracy, for doctors to trust your report. How much is it? You understand? So we need to buy it. Also, when a lady comes with that severe low abdominal pain, I had a case. A severe low abdominal pain. So in the consulting room, I was thinking is you see, it's the lady. So I was thinking about the appendicitis and a possible ectopic. But when we did PT, it was negative. That means ectopic is out. We did serum and urine PT. It was negative. Ectopic is out straight. So that has freed me from that side. Now, what about the rest? So the appendicitis, you do your physical examination, then you can query appendicitis. But when the labs came, I saw that it was PID. And the urine, I could see it, PID. Then the scan also showed some features of PID. So we started treatment for PID, and the patient got, well, I think 3 days. Right. So you see, PID, severe PIDs, acute ones can cause severe low abdominal pain, tenderness, the same way as appendicitis and the ectopics also what okay, you understand. So please, for the ladies, don't just diagnose appendicitis straight away because there are other structures there. Appendicitis is typically caused by obstruction. Appendicitis is typically caused by obstruction of the appendiceal lumen. We are talking about the causes. Obstruction of the appendiceal lumen with resultant buildup of fluid, suppurative inflammation, secondary infection, venous congestion, ischemia, and necrosis. I will explain this. Let me use these images to explain, then we go back. So, this is the appendix, normal appendix. Don't forget that the appendix is part of the intestines. The appendix is part of the intestine. And so, the intestine, they have crypt cells, they have cells in the mucosa, and the cells produce fluid, like the gallbladder. The cells produce fluid in the intestine lumen, so that they will ensure easy passage and they will prevent friction. Now, the appendix too has the cells, and the cells are in the appendix. They also produce fluid. So when the appendix gets full, it will discharge the fluid into the cecum, and it will mix with the feces or the undigested food, and then it will move up. That is what the appendix does. So as it is discharging its content into the cecum, the fluid contains normal flora that will be discharged into the cecum. So as you are going to toilet, definitely some of the normal flora, they are in. So the appendix will have to be replenishing them all the time by discharging its content into the cecum all the time. Now, maybe you ate, and a seed blocked the entry into the appendix, and it's fixed hard over there. Now that is an obstruction. Now the appendix will continue to build its fluid. That one is a natural thing. So the appendix will continue to create or produce its fluid. When the appendix is full, it will have to be discharged into the cecum. Now there is an obstruction. The appendix cannot discharge the content into the cecum. What happens? The appendix will start to be enlarging. Look at this, please. Building more fluid, mucus. The fluid will continue to be produced because the appendix doesn't know that it is obstructed. So it will continue to produce its fluid. When the fluid is becoming too much, a structure that looks like a worm, meaning it is tiny, so it shouldn't expand that much. Don't forget, the appendix is part of the intestine, so it has blood vessels around that the blood vessels supply the appendix with what? Nutrients. And lymphatic vessels also there. Now, if the appendix starts to enlarge and enlarge and enlarge, what happens? The blood vessels in the submucosa, the blood vessels supplying the appendix in the submucosa, due to the pressure buildup in the lumen, the pressure in the inside of the appendix, will block all the blood vessels supplying the appendix. The pressure is too much for the appendix because the thing is tiny. Why should it enlarge like that? The pressure will block all the veins and the arteries that supply the appendix. It will block it. That's the ischemia. When the arteries and the veins are blocked and the appendix continues to enlarge because there is obstruction and it can't discharge its content, what happens? Now the appendix will lack blood. Since it is lacking nutrients, the cells of the appendix will start to die. This is the pathophysiology of appendicitis. The cells of the appendix will start to die. Now look at the color, and this dark color in the appendix means that the appendix is undergoing necrosis, necrotic changes, tissue death, infarction, like infarction. Over here, look at the wall. It was big enough, nicely. But look at here. The pressure in the lumen, the fluid buildup has compressed the wall to the extent that the blood vessels are obstructed and the appendix tissues will start to die. When the appendix starts to die, it's like it is macerating, it is rotten. If it is dying like this, then the appendix will become soft because of also the distension. The pressure will increase. And when the pressure continues to increase, the appendix has no option than to what? Rupture. So over here, it will rupture and form gangrene. Gangrene means that there was no blood supply, and then the tissues died, and the tissues are undergoing necrotic changes. They are rotten, they are macerating, they are dying out. They will form gangrene. Gangrene will form when the thing is depleted with oxygenated blood and nutrients, and then there is a bacterial invasion or microorganism invasion, mostly for gangrene bacteria. They'll act on it. They'll act on the structure and infect it again. Then we have the gangrene over there. But though we have gas gangrene and the rest, we have some gangrenes that are not with initially not bacteria, but later there will be bacteria invasion to cause it to be very severe. Now, when this appendix ruptures, what happens? All the suppurative contents, the infectious contents, the normal flora, they will be discharged into the peritoneal cavity. Now, they are not supposed to be in the peritoneum, but they are there right now. They will tend to be opportunistic bacteria and start to cause severe infection in the peritoneum. That is what will bring about the tenderness. So when they cause severe infections, every part of the abdomen will be tender. Appendix is whether it is ruptured or not, there will be tenderness. But when it ruptures, the tenderness will be generalized. All abdominal corner. So let's go back. Let's come here. Over here there is an obstruction, appendiceal obstruction, early appendicitis, visceral peritoneal irritation. When there is early appendicitis, the visceral peritoneum, I told you that the peritoneum, there is parietal and viscera. The viscera lines the organ directly, and the parietal lines the inner cavity of the whole peritoneum. And so there is a visceral lining on the appendix. So when it is obstructed and it starts to enlarge, the visceral peritoneum will start to be irritated. That will start to give you some pains. Then the appendix will be distended. As it is distended, there will be the obstruction of blood vessels. So distension causing ischemia, obstruction. So there will be irritation of the parietal, irritation of surrounding peritoneum. That is the viscera, and it will be also affecting the parietal over there. So for the visceral peritoneum, the pain may be centered. The pain may be centered around the most of the time the umbilicus, sometimes getting to the epigastrium when there is early inflammation. Then when it affects the parietal peritoneum, the pain will move down. It will move to the right iliac fossa. That is around like after 12 hours, between 12 and 24 hours of the irritation, of the obstruction, the pain will come there to the right iliac fossa, because that is where the appendix is. It will center over there. Now, when it ruptures, that means it has perforated. It has perforated, and there will be generalized peritonitis, because the suppurative content over here will be discharged into the peritoneum to cause severe peritonitis, inflammation of all the peritoneum. So, of obstruction, we are saying that there will be appendiceal lumen obstruction leading to resultant buildup of fluid. The fluid will be built with suppurative inflammation. Suppurative means that infectious inflammation, because you see the appendix has the organisms already. So when you create a conducive environment for them to thrive, then they will also use that as an opportunity and harm you, because the fluid buildup will cause them to also replicate as fast as possible and harm you. Secondary infection because of the inflammatory processes. Venous congestion, and don't forget the normal flora in there. Venous congestion because of the pressure buildup. Ischemia, pressure buildup, and necrosis. So when there is ischemia, no blood to the appendix, and it will undergo necrotic changes. So obstruction may be caused by fecolate or fecal stasis. And so it's better you go to toilet every day. Those people that have trained the body that they go to toilet every 3 days, please, it's not hygienic. Every day you have to train your system that every morning at 6 a.m. I'll go to toilet, and your system will pick it up. So fecolate is hard feces or fecal stasis, where the feces, they are not moving, they are staying at one part in the colon. Fecolate feces can be hardened, we call it fecolate, and block the entry into the appendix. Some mucosal lymphoid hyperplasia, when you have some infections in your intestines, enterocolitis and the rest, they may cause the lymph node in the intestines to go big. They can go big, though they are temporal, but they can go big for like 5-7 days and can block the entry into the appendix. So the appendix will be inflamed at that time. Inspissated barium. When you are going in for CT scan or the MRIs and some of the X-rays, sometimes you are given a dye to drink. If it is with the gastrointestinal tract, you are given a dye to drink. When you drink, then they capture the image. So when you drink the dye can form thickened substance, and also can go and obstruct the lumen of the entry into the lumen of the appendix. We call it inspissated barium. Barium is actually a substance that they give for people to drink. So when it forms something like a tumor and blocks the entry, we call it barolate. Vegetable or fruit seeds, the rough ones, like the pepper seeds, and they are fond of obstructing the lumen, the entry into the lumen. Worms like Enterobius vermicularis, worms, the worms, the roundworms and the rest, they can kill and block the entry into the appendix. Tumors of the cecum or appendix. When someone develops tumors in the cecum or tumor in the appendix, can also block the entry into the appendix. Now look at this. This is a normal appendix, but the person has gone for it to be removed. This is an inflamed appendix. Look, this is an inflamed appendix, and this is a ruptured appendix being preserved. This is a ruptured appendix. It ruptured, and then they took it out during surgery. Symptoms. Please, the symptoms are very important. Take note of them, because as I said, appendix, you are not going to use only ultrasound to diagnose. We need history and physical examination. If you don't know your history, you can't diagnose appendicitis. Abdominal pain is the prime symptom of acute appendicitis. Classically, pain is initially diffusely centered in the lower epigastrium or umbilical area. It's moderately severe and steady, sometimes with intermittent cramping superimposed. What we are saying is that abdominal pain will start and is the prime symptom of acute appendicitis. Though sometimes anorexia will start first, but the pain is classical and it starts below the epigastric region, sometimes at the umbilicus, and it is moderate in severity. It is steady, sometimes with intermittent cramping. So sometimes the pain will be there and it can be severe. Then it comes down like that. And after a period varying from 1 to 12 hours, but usually within 4 to 6 hours, the pain localizes to the right lower quadrant. So initially, the pain will be diffusely centered around the umbilicus, the navel, and below the epigastric region. So you have to take the history as such. Where did the pain start from? You ask, the person will tell you. So between 4 to 6 hours, but up to 12 hours, the pain will move from that side to the right iliac fossa or the right lower quadrant, telling you that it is appendicitis. Now, we have anorexia, nearly always accompanies appendicitis. Appendicitis without anorexia, then it may not be appendicitis. So anorexia means, let me say, literally loss of appetite. But we have two types. We have anorexia bulimia and anorexia nervosa. So anorexia nervosa means that the person doesn't want to eat because the person thinks that when he or she eats, she will be fat or obese. That is anorexia nervosa. Anorexia bulimia means that the person wants to eat and becomes fat. So the person will eat and eat and eat like 6 times a day, 7 times a day, anorexia bulimia. Now, for this anorexia we are talking about over here, it is for the nervosa. But for the nervosa over here, you the patient there, it is not you that have decided not to eat, just that you don't have appetite for food. And in this way, you don't have appetite for food, and sometimes anorexia will even start before the abdominal pain will start. So we are saying that it is so constant that the diagnosis of appendicitis should be questioned if the patient is not anoretic. So if I'm in the consulting room and a sonographer writes appendicitis, I also take my history and do my physical examination and find out if it is true. Unless the ultrasound has seen fluid, meaning there is a rupture of intra-abdominal hollow viscous, and the appendix can also be ruptured. So for anorexia, please take note. Vomiting occurs in nearly 75% of patients. Note, vomiting should come after the onset of pain. So if there will be vomiting, because not all patients with appendicitis vomit, but if there will be vomiting, it should come after pain. Vomiting coming before pain is bowel obstruction. But for appendicitis, it should come after the onset of pain. Now, obstipation. Obstipation is absolute constipation. Obstipation is about like maybe more than 1 week, no toilet, sometimes 2 weeks. So when it is 7 days, you haven't passed feces, then we call it obstipation. For obstipation, you won't even pass flatus. Obstipation, absolute constipation. And the reason is that, you see, with the ANS, the autonomic nervous system, it regulates the intestines. So once part of the intestines is injured, maybe there is appendicitis, so the nerves over there will be firing messages to the autonomic nervous system that I am injured. And so the autonomic nervous system will send a feedback message to the intestine that stop peristaltic activity. because I don't want you to continue to be injured. The body thinks that once there is an injury to part of the intestines they don't have to move to further cause injuries. You understand? So automatically, the autonomic nervous system will stop peristaltic activities. That's why you will get constipation. If the intestines are not moving, the food that you eat will not move. And so the undigested food in the colon will not move. So you'll be constipated. That is it. In greater than 95% of patients with acute appendicitis, anorexia is the first symptom. So the symptom sequence, anorexia. Listen, anorexia is the first symptom, followed by abdominal pain, which is followed in turn by vomiting, if vomiting occurs. So the anorexia, we are saying that in greater than 95% of patients with acute appendicitis, anorexia is the first symptom. If vomiting precedes the onset of pain, the diagnosis of appendicitis should be questioned, because that will be a bowel obstruction. Vomiting coming first before pain usually is associated with intestinal obstruction or bowel obstruction. Signs. So temperature. So what are you going to elicit to make sure that there is appendicitis? Well, the signs are those that the elements that you, the prescriber or the sonographer, you are going to find it yourself. Symptoms are those that the patient will tell you herself or himself. If the patient doesn't tell you, you wouldn't know. Those are the symptoms. Signs. Temperature elevation is rarely greater than 1 degree Celsius. Late findings in rupture, after rupture. So for appendicitis, their temperatures are mostly normal. And it may be 1 degree Celsius above the normal when it ruptures, the appendix ruptures. And it discharges the suppurative content into the peritoneum to cause peritonitis. Pulse rate is normal or slightly elevated. So the heart rate or the pulse rate will also be normal. If it were elevated, it will just be slight. Tenderness often is maximal at or near the McBurney's point. So tenderness is maximal. That means that at the McBurney's point, when you press, the patient will feel pain. Tenderness is pain on touch. So as you haven't pressed, the pain may be there, but it wouldn't be severe. But when you press, there'll be severe pain at the McBurney's point. Rib-bound tenderness. Rib-bound tenderness means that you can press gently and you release your hand abruptly. You release your hand with force, but it should be gentle release. The patient will shout. Rib-bound tenderness. The Rough-Sink sign. Rough-Sink sign is, you see, the appendix is at the right iliac fossa, but you will palpate on the left iliac fossa, and the patient will feel pain in the right iliac fossa. That should tell you that there is appendicitis, inflamed peritoneum. Pain in the right lower quadrant when palpatory pressure is exerted in the left lower quadrant. That is the Rough-Sink sign. Then there is also a sign called muscular resistance, which we call it guarding. So the patient will be guarding the abdominal wall. So the patient, as you are trying to palpate, the patient will tighten the abdominal wall. The patient will tighten the abdominal wall so that it will be tensed. That is guarding, muscular resistance. And to palpation of the abdominal wall. Actually, it parallels the severity of the inflammatory process. So the tensed the abdominal wall, the higher or the greater the inflammatory process. So a sign, you have to place the patient in left lateral decubitus. We went through this position when we were treating the abdominal anatomical review. Left lateral decubitus. Position the patient there and extend. When you position the patient there, you have to hold the right leg and extend it to the hip. When you hold the right leg and you are extending it, like the right leg is down, The patient is lying on the left lateral decubitus. Then you try to what? Extend the right leg. As you are extending it, the psoas muscle will be stretched. And when the psoas muscle stretches, it will compress the appendix. And when there is inflammation, the patient will feel severe pain. So you tell the patient that I'm about to do this. When you feel pain, let me know. So the moment there is pain, it means psoas sign is positive, and it means appendicitis. Obturator sign, as I said, the ectopic pregnancies too. When you do all these examinations, you may find them positive. That's why for ladies, you have to do urinary pregnancy test to rule out pregnancy before you think of that. Obturator sign. Obturator sign of hypogastric pain on stretching the obturator internus indicate irritation in the pelvis. I earlier showed you the obturator internus muscle, and that muscle, you saw that the appendix was lying on it. So the test is performed by passive internal rotation of the flexed right thigh with the patient supine. Passive internal rotation. So you are going to be turning the leg. Passive. Passive means that the patient is not going to burn any energy, because it is you, the examiner, who is going to hold the leg and internally rotate it. So you have to let the patient lie supine, and you hold the right thigh, you flex it, the right leg, and you flex it at the thigh, and you start to rotate the right leg to the right and left. When you are rotating it, the obturator internus muscle will be stretched, and it will compress the appendix. Then the patient will feel pain, and the patient will tell you that it is paining me. That means obturator sign is positive. Diagnosis of acute appendicitis. Acute appendicitis is normally diagnosed clinically. Clinically, meaning when we say clinical diagnosis, we don't need labs, we don't need imaging, we need only the hands, only your hand, and the questions that you ask the patient. So the gold standard for detecting appendicitis is laparoscopy. What's the difference between laparoscopy and laparotomy? So tomy means that you cut and you open. So laparotomy, you have to cut and open, and you go in there. So all the abdominal surgery that's going on in our country are almost always laparotomic surgery. But for laparoscopy, it is an emerging technique that the surgeons will actually use something we call trocar. Something called trocar. There are 3 or 4. They will insert the trocar. The trocar contains a camera in front of it, and it can also hold a scalpel blade at the tip of it. So they will just puncture the abdominal wall with the trocar, about 3 or 4. One at the epigastrium, one at the left side, one at the right side, one maybe below the umbilicus or something, and they will go in there, and they will be, since the trocar contains camera, they will be watching, and also lights. It has lights. They will be seeing everything on the screen, and they use that to do surgery inside without cutting the person. And they only puncture the abdominal wall and get into the abdomen, but you don't cut the person. So those surgeries, the moment you are done, the person can go to work that same day, because you didn't cut. You only punctured the abdominal wall. And that one, it can go straight to see the appendix, and they will visualize it on the screen, real time. So it is the gold standard for detecting appendicitis. If that one is unavailable, you can do CT scan. Acute appendicitis should be suspected in anyone with epigastric, periumbilical, right flank, or right-sided abdominal pain who has not had an appendectomy. So someone who is having all these features and the person has never had any surgery on the appendix, then you can suspect appendicitis. Women of childbearing age need a pelvic exam and a pregnancy test, as I said. Ultrasound and abdominal X-ray are only needed as a supportive diagnostic tool. CT scan is highly diagnostic. Yes, ultrasound and abdominal X-ray is for what? Support, but CT scan is highly diagnostic. Because something the Alvarado score or the Mantrell score, the prescribers and the doctors, they are aware of this. When someone comes, we do the Mantrell score and we score the person. Based on the score, we can say it is appendicitis or it is unlikely to be appendicitis. So we the Mantrell, M-A-N-T-R-E-L-S, Mantrells. So the M means migration of pain to the right lower quadrant. You have to ask the patient if the pain started elsewhere and migrated to the right lower quadrant. If the patient says yes, score 1. If there is anorexia, let me say loss of appetite, even before the pain started, score 1. Please, have you been eating since the pain started? Do you feel like eating? The person will tell you. You score 1 if it's positive. Nausea and vomiting, if they are there, you score 1. If they are not there, 0. Tenderness in the right lower quadrant, if they are there, 2. Your tenderness is a bit specific, so you score 2. Tenderness in the right lower quadrant when you do your examination. Rebound pain. So when there is rebound tenderness, like you press and release abruptly and there is pain, you score 1. Elevated temperature. You have to have your thermometer. When you check and it is elevated, when you are in the hospital, you can just check the folder or yes, and then you find out the temperature. If it has elevated more than 37.5, you can score 1. Leukocytosis, you have to do full blood count. When the full blood count comes out, the doctors will check. So as a sonographer, you can end at the rebound pain. But if you are at the facility, you can also check for the elevated temperature. If you are at a hospital or something, or a clinic. But a diagnostic center, you may not have the thermometer. So you can end there. But in the hospital, we have to check the L, which is the leukocytosis. Meaning when you do a full blood count, the white blood cells will be elevated, especially the granulocyte or the neutrophils will be elevated. Then you see, as for the S, it is specific to the neutrophils. The S is shift of white blood cells to the left. We are specific with that, with the neutrophils, meaning the neutrophils will be elevated. But the L is leukocytosis. Specifically, it is general, not even specific. With the L, it is general white blood cells. So when the white blood cells, the WBCs are elevated, you can score 2. But with the S, it's specific to the neutrophil. When they're elevated, you score 1. Afterwards, you sum up all of them, and it is up to 10. It is up to 10. Now, a score of 1 to 4. Acute appendicitis, very unlikely, keep under observation. A score of 5 to 6. Acute appendicitis possible for regular observation. When you get 5 to 6, it can be possible, but you haven't confirmed that. So you should admit, and then do further tests, and also regular observation because the person has been admitted. For 1 to 4, we can give some drugs and let the person go. For 7 to 8, acute appendicitis probable, you have to operate. 7 to 8, it is probable you have to operate. 9 to 10, acute appendicitis, very probable, operate. Now, appendicitis on ultrasound. So this is the appendix, like a web. This is the appendix. Okay. Let me tell you this. All these images were taken from online, and so most of them are from the foreign world, and their machines are very powerful. Don't think that the images you are seeing here that are very clear like this, maybe your machine can also see them. You need powerful machines to also see them. We have powerful machines in Ghana that you can use to see them, but some machines too, they are not quality, and you may not see them nicely as this. You understand? So ultrasound with its lack of ionizing radiation should be the investigation of choice, because ultrasound doesn't radiate, doesn't have any radioactive waves, so it doesn't cause any harm. With a competent user, ultrasound is reliable at identifying abnormal appendices, especially in thin patients. However, the identification of a normal appendix is more problematic, and in many instances, appendicitis cannot be ruled out. The doctor will write pain in the right lower quadrant, rule out appendicitis. Then the patient will come. You see, when the appendix is normal, it's difficult to see. When the appendix is inflamed, it is easy to see. Because when it is inflamed, it becomes big. When it is normal, it is just tiny like a web. And that right iliac fossa, there are a lot of structures there too. So if you don't take care, you won't see the appendix. Especially when it is the retrocecal, you won't see. The technique used is known as graded compression. You see, someone is having severe right-sided abdominal pain, and you are going to press your probe over there. You see, it's painful. The person may not allow you to do that. So you have to know the technique you use. Graded compression. Using the linear probe over the site of maximal tenderness with gradual increasing pressure exerted to displace normal overlying bowel gas. That's graded compression. What it means is that you have to put the probe there at the right iliac. Don't press it forcibly. As you put the probe there, the patient will tell you that it is paining me. Just assure the patient that I will make sure the pain will come down. So then you press small, and it will pain the patient, but when you press more, you maintain the pressure over there. Don't release, let it be there. Then you press again, maintain the pressure, don't release. You press again like that, graded compression. Because when you press and you are pressing, and you grade the compression, the body will adapt to it. But when you put the probe there and you press force like that, the patient will push your hand because it is painful. So you should grade the compression. Grade it. You have to make a gradual process. Increase the pressure gradually, and it will displace the overlying bowel gas so that you see the appendix. Now we have a way of also trying to capture the appendix. A dynamic ultrasound technique using a sequential 3-step patient positioning protocol has been shown to increase the detection rate of appendix. It was coined by the American College of Radiology and the American College of Emergency Physicians. So it is a 3-step patient positioning. First step, examine the patient in a conventional supine position. So let the patient lie the normal way, supine, and capture try to examine the appendix. Afterwards, you have to let the patient lie on the left posterior oblique position at an angle of 45 degrees. And then you take a second look at the supine position. So first, supine position. Don't forget, in the supine position, the bowels may cover the appendix. Then let the patient lie on left lateral position or left posterior oblique. When the patient lies on the left, the bowels will be shifted. The bowels will be shifted from the right side to the left. And so the appendix will be freed. So you take a second look, so you capture it. You capture the appendix at that angle. Afterwards, take a second look. Let the patient lie supine again and take the appendix. So it is suggested that the effect of the left posterior oblique positioning step improves the acoustic window by shifting the bowel contents. So the colon, the bowels will be shifted when the patient lies on the left posterior oblique, so that the appendix will be freed and you see it. This is the appendix. This fracture is the appendix. Nicely, this is the appendix, normal appendix. You see, when you are measuring the appendix, you stand here and you drag your hair there. You stand here where it is dark. You drag it here. That's the diameter of the appendix. Diameter of the appendix. Then we have the appendiceal wall. The wall is just this one, the hyper thing here. That is just the wall. We'll talk about it. So this is the longitudinal section, which is sagittal, which will look like a worm, and this is the transverse section, which will look like a circular object. The measurement of appendix. The appendix has a proximal and distal part. The proximal part is the part that is closer to the cecum, that's attached to the cecum. Proximal means it is close. Distal means it is far away. So distal part is far away from the cecum. Normal appendix diameter is less than 6 mm. Take note of it. The normal diameter is less than 6 mm. Normal wall thickness is less than 3 mm. The wall thickness should be less than 3 mm. So when you measure the wall, this hyper wall, it should be less than 3 mm or up to 3. It shouldn't go beyond that. When you are measuring the diameter of the appendix, you stand from here and you measure up to this place. And that is the diameter, the dark areas. That's the diameter, and it shouldn't go beyond 6. The appendix has a proximal, I think I've said this. Now let's talk about the 369 rule. 369 rule is simple aid memoir describing the normal bowel caliber. Simple aid memoir means that it is there to help you memorize the size of the intestines. So large bowel, small bowel measures less than 3 centimeters. You can get 2.5 centimeters or less, but we take it as less than 3 centimeters. The small intestines. Bowel is the same as intestines. The large intestines measure less than 6 centimeters. The appendix measures less than 6 millimeters. The appendix, millimeters. The cecum is part of the large intestine, but the cecum is big, so it is less than 9 centimeters. Have you get it? So this is where we get the 369 rule. All of them are in centimeters with the exception of the appendix. Above these dimensions, the bowel is generally considered dilated and obstruction should be considered. If you get the measurement above these dimensions, then there is a problem. So you can see a normal proximal appendix. There is the proximal appendix. Proximal, normal proximal. You measure and you get less than 6. You see, the person got here 3.6 mm or 0.36 centimeters, 3.3 mm or 0.33 centimeters. That means it's not up to 6. It's not up to 6. It's tiny. So it's normal. Now let's look at the distal appendix here. This is a distal appendix. This is an artery. You will see it beating. Rim. It's an iliac artery. This is a muscle. This is a muscle. So look at the distal appendix. It contains fluid. When the person measured, it is 1.09 centimeters, almost 11 mm. Almost 11 mm. Something that shouldn't go beyond 6. We have an 11. So it is what? Here is inflamed. Dilated appendix. Ultrasound as supportive diagnosis of acute appendicitis. You will see a peristaltic, non-compressible, dilated appendix greater than 6 mm outer diameter. So when the appendix is inflamed, when you press your probe deeply, it will not compress the appendix. When it is not inflamed, the appendix can easily be compressed with pressure. Because it is inflamed, there is fluid buildup, the walls are edematous, the walls are swollen, and so you can't compress it. Aperistaltic means that the intestines are not moving. The appendix will also be dilated, greater than 6 mm in diameter. Appears round when compression is applied. When you force yourself and compress it, and you stand on long transverse, it may appear round. Hyperechoic appendicolate with posterior acoustic shadowing. When we say appendicolate, it is something like a stone in the appendix. It happens when there is appendicitis. It means there is fat, aggregated fat. The fat has hardened, and it is like a stone found in the lumen of the appendix. We call it appendicolate. So when you see it, it is also specific for appendicitis. Distant appendiceal wall layers. So the appendix, it doesn't have to have a distant wall. The wall doesn't have to be too nice and thick. But when there is appendicitis, the walls will be thick. Echogenic prominent pericecal and periappendiceal fat. So fat will be built on the appendix because of the inflammatory processes. Fat will be built on the appendix and the cecum, pericecal. Periappendiceal hyperechoic structure, amorphous hyperechoic structure, usually greater than 10 mm, seen surrounding a non-compressible appendix with a diameter greater than 6 mm. So we are describing this one. You can see that the appendix is enlarged. This is in transverse section. And you can see it is too hypoechoic. When you measure the diameter, you get more than 6 mm. And we are saying that the structure over here measures more than 10. But the diameter of the appendix is more than 6. And there is mural hyperemia, periappendiceal fluid collection. So you can see some hypoechoic structure around it. That means there is tiny fluid collection, tiny, very scanty. Wall thickening greater than 3 mm and above. So when you measure the walls where the blood fluid, the color of light is, when you measure the wall, you start from here and you measure the wall up to this place, you get more than 3. Also, mural hyperemia with color fluid Doppler increases specificity. If you put your Doppler and you are seeing the flow on the walls, the submucosa, the walls, then it is specific for inflammatory processes. Vascular flow may be lost with necrotic changes. Now, when the appendix starts to undergo necrosis, then when you put Doppler, there will be no flow because the cells are dead. So this is the appendix. This is the appendix. This is the appendix. You can see it. A very nice structure, but it is enlarged. This is enlarged appendix. This is with compression on transverse. With compression, we are seeing the appendix as this. Compression. Without compression, we are seeing it as this. So with compression, it's more clearer than without compression. This is appendicolate. Appendicolate, the whitish structure from fat buildup in the appendix. The moment you see it, it's appendicitis. It is too thick, so it will cast shadows here. Appendicolate. Another appendicolate in the appendix with resultant buildup of fluid. Buildup of fluid. You can see the shadows that the appendicolate is casting. This appendix is severely inflamed. You can see it. It hasn't ruptured, but it is inflamed. You can see fluid buildup in it, and the walls are too thickened. So, certainty of inflamed appendix. Confirming that the structure visualizes the appendix is clearly essential and requires demonstration of it being blind ending and arising from the base of the cecum. So before you can say what you have captured is appendix, it should have a blind ending. Normal appendix, it has a pointed ending. But when it is inflamed, it becomes blind ending and arising from the base of the cecum. You should start from the cecum. Identifying the terminal ileum confidently is also helpful. So I told you that the ileum joins the cecum at the ileocecal junction. So if you're able to see the ileum and you are seeing the cecum, then you can see the appendix. But it's not easy to. So you can see the appendix here with fluid outlining the tip of it. So there's a blind ending tubular structure with free fluid outlining the tip. Blind ending, it is not pointed. You can see it is blind ending with fluid. So it's inflamed appendix. Limitations of ultrasound. Retrocecal appendix may not be visualized with ultrasound. I've told you already. Perforations may be missed due to return to normal diameter. So if the appendix ruptures, then it will return to normal diameter because all the content will be spilled out. So ultrasound may not see, but ultrasound will see the fluid in the peritoneum. Perforated appendix. So you can see that this is the part of the appendix and it has perforated. And this is purulent collection. It has discharged its content into the peritoneum. Purulent collection. And over here too, we have the appendix over here. We have the appendix over here, and you can see that the appendix is ruptured and it has discharged its contents here. It has discharged its content here. Appendicular abscess. It is a complication of acute appendicitis. It results from the invasion of the appendix by bacteria following an obstruction. Invasion of the appendix by bacteria following an obstruction. So when the appendix is inflamed, you don't do anything about it. Then the bacteria in it will be opportunistic and they will start to cause infections and subsequent abscesses. This can discharge suppurative content into the peritoneum when it ruptures. In severe cases, the pus can mimic ascites. You see, when there is appendicitis, and you don't do anything about it, and it forms pus, it forms abscesses. And it ruptures. The pus can build up, and if you don't take care, it may look like ascites. Ascites is what? Accumulation of fluid anywhere in the abdominopelvic cavities. Accumulation of fluid. We treated it when we were treating liver cirrhosis. So this is the uterus. This is the bladder. You can see fluid outlining the uterus. That is abscess from the appendix. Now there is fat. The appendix is here, and there is abscess. There is fat again. So the appendix is here. There was inflammation, appendicitis. Now it is discharging the suppurative content, the pus in the peritoneum. That is appendicular abscess. Bowel obstruction. Bowel obstruction. So you can see an image here showing ballooning of part of the intestine, point of obstruction. Bowel obstruction or intestinal obstruction. Intestinal obstruction is a blockage that keeps food or liquid from passing through the small or large intestine. It is also referred to as mechanical intestinal obstruction. It is classified into two, namely small bowel obstruction and large bowel obstruction. Small bowel obstruction, large bowel obstruction. Small bowel obstruction accounts for 80% of all mechanical intestinal obstructions. The remaining 20% results from a large bowel obstruction. It has a mortality rate of 5%. A mortality rate of 5%. So the small bowel obstruction, the lumen is small, so it can easily be obstructed. That's why it forms about 80% of all obstructive cases. Large bowel, the lumen is large, and so it's not mostly obstructed. It can kill up to about 5% of cases. That means that the pain with it will let the people come to the hospital. So it doesn't normally kill. What are the causes of small bowel obstruction? Adhesions or scar tissue that forms after surgery. So when you do surgery, any surgery at all, and the structures are not positioned at where they were before, when they get closer to each other that much, they will start to build some bands. We call it bands, adhesions. I'll show you some images. And the adhesions, it will build from one organ and attach to the other organ. So they will be holding themselves. Foreign bodies, objects that are swallowed and block the intestine. So like children can swallow bones, they can swallow coins and can block the intestines and cause bowel obstruction. Gallstones is rare, but gallstones are tiny ones. So it's rare. Hernias. A hernia in the abdominal wall. As the intestines are moving, the intestine can go and enter the hernia. Hernia is just a protrusion, like abnormal closure of a body part. So when there is a cavity in the wall, as the intestines are moving, they will find their way into the cavity and it will cause hernia. When the intestine find their way into the cavity, in the cavity, they may not be able to undergo the peristalsis because it is fixed in a cavity. And when food gets there, it will halt. It will be obstructed over there. That is hernias causing bowel obstruction. Impacted stool. Constipation, severe constipation will cause can cause bowel obstruction because it will block the free flow of bowel contents. Intussusception happens in children up to about 2 to 3 years. Intussusception is when one of the intestines will fold on itself and the other one will come and enter. I'll show you how it is. Intussusception, it causes bowel obstruction. Tumors blocking the intestines. Any tumor that blocks the intestine too. Volvulus is twisting of part of the intestine. When the intestine twists, it will block the intestine. Intestinal atresia, when part of the intestine didn't develop well, it didn't grow, or constriction, it causes bowel obstruction. That's a terror. Look at this. This one is adhesion. This is adhesions. Have you seen the bands? The bands are wrapping around the intestine. So this one will prevent the intestine from moving well and from effective peristalsis. So it will cause obstruction. During surgery, they found out the adhesions. This one is a foreign body. The person swallowed it. Foreign body. It will block the intestine completely. This is hernia. Look at the intestines. They are here, and there is a cavity in the abdominal wall. So the intestine passed through the abdominal wall and came to just under the skin. So this place, food cannot get there, so it will be obstructed. Incarcerated hernia. Then tumors. So we have cecum over here, and there is a tumor here blocking the cecum. It can cause obstruction. Impacted stool, feces. So this is a stool. It has obstructed the bowel, the intestine. This is volvulus, twisting of the intestine, volvulus. And this is intussusception, telescoping of one segment of the intestine in, and the other part of the intestine will come and enter. This one will cause intussusception. It will block the bowel and cause bowel obstruction. Now, pathophysiology of bowel obstruction. How does it occur? The essence of intestinal obstruction is that there is a blockage in the intestine. Impairment of the passage of material through the bowel results in cessation of passage of flatus and feces. Blockage results in distension of the proximal intestine with solids, fluids, and gas, which results in pain and increase in abdominal gait and increased tension in the abdominal wall. What we are saying is that when part of the intestine is obstructed, let's say at the jejunum there is an obstruction, that means any food you eat, digestion will start. The food, when the food gets to the jejunum, there is an obstruction and the food will remain there. It will move to the ileum for further absorption. It will remain there. You eat again, it will go there, get to the jejunum, it remains there, and it will be piling up. So it will be piling up over there, creating increased pressure. But the bowels will be dilated because of the piling up of what? Intestinal content. So it will increase the pressure, distend the abdomen, distend the proximal bowels. Because you are drinking fluids, you are eating solids. The fluids will distend the bowel, the proximal point of the bowel. And you start to feel pain because the intestines are being distended. Increased tension in the intestinal wall or impairment of the blood supply results in necrosis and perforation of the bowel. So if you don't go to the hospital for them to find out and you continue to eat and drink, the intestine will be full with the fluids because there is an obstruction. The proximal part will be full and then you start to vomit. Then the pressure in the intestine will block all the blood vessels that are supplying the intestine with blood. So the intestine will lack blood and will start to undergo infarction, tissue death. Finally, when the tissues are dying, it will be soft and perforate and release all the contents into the peritoneum. This may cause paralysis and also translocation of bacteria into the peritoneum, causing peritonitis. So if the intestines begin to undergo this kind of inflammatory processes, the ischemia, necrosis, then the autonomic nervous system will not cause the intestine to move again until it is resolved. So that will cause what? Paralysis of the intestine. We call it paralytic ileus. And so the intestines will not move. The intestines will not move. They will not move anywhere. So paralytic ileus, when the ileum or the bowels are not moving, bowel paralysis, because we have been injured with bowel obstruction. Then when it ruptures, there will be translocation, movement of bacteria in the normal flora into the peritoneum, and they will start to cause peritoneal inflammation, which we call peritonitis. Symptoms and signs of acute bowel obstruction: abdominal swelling, which we call abdominal distension. Yes, bowel obstruction will cause the abdomen to be distended. Sometimes during physical examination, you see that the abdomen is having peristaltic movement. The abdomen will be moving like that. Early stages of bowel obstruction, the peristalsis will increase. You will feel that your intestines are moving. Early stages. But late stages, when there is ischemia and necrosis, the intestine will stop completely. They will not move. Abdominal swelling, recurrent cramping, and abdominal pain. The pain can occur around the belly button, around the umbilical. Nausea and vomiting, severe bloating. Severe bloating. So there will be gas. There will be accumulation of gas in the intestines. Constipation and lack of gas. Lack of gas means that though the intestines have gas, but you can't pass the gas out. Flatus, you can't pass flatus because there is an obstruction. If the intestine is completely blocked, the gas will not come out. But we have partial obstruction. That means that one you can still pass flatus, but you can't go to toilet. Decreased appetite because the intestines are blocked. The intestines are failed. You may not even feel like eating. Constipation because the intestines are not moving. Late stages. Intussusception is the commonest cause of bowel obstruction in children less than 2 years, but now it is up to 3 years. Child draws knees up to his or her chest. So look at this child, look at the abdomen. It is too distended. So the abdominal muscles will automatically flex the legs. Because you can't extend the leg. If you extend the leg, there will be severe pain in the abdomen. So you have to flex it like this to reduce the tension in the abdominal wall muscles. There's an adult in the theater about to be operated upon. So intussusception and its subtypes. An intussusception is a loop of bowel telescoping into an adjacent loop of bowel. There are 2 subtypes of intussusception. We have the ileocolic intussusception, and so ileocolic means that ileum to the colon. So the colon will actually form something like a fold, and then the ileum will go into it. Ileocolic intussusception, and small bowel to small bowel intussusception. That one, it can be ileum to jejunum, jejunum to jejunum, or jejunum to duodenum, any. The receiving loop of bowel is called the intussuscipiens, and the inner bowel is called intussusceptum. Cipiens means it is receiving it, and the one that's going inside is intussusceptum. In adults, intussusception is very rare. It doesn't normally occur in adults. In both children and adults, it is usually the result of medical condition or procedure, including a polyp or tumor. A polyp in the intestine can cause intussusception to occur. Scar-like tissues in the intestine, like adhesions in adults, will cause intussusceptions, or other surgeries on the intestinal tract, adult or older children. Some surgeries after surgeries can also cause intussusceptions. The pathogenesis of idiopathic intussusception. Idiopathic means no known cause. So the cause of idiopathic intussusception is not well established. We don't know some of the causes of intussusception. It is believed to be secondary to an imbalance in the longitudinal forces along the intestinal wall. So what will cause the intestine to be moving? They are forces. And those forces, when they become imbalanced, it may cause one part of the intestine to fold and the other part to come into it. Both ileocolic and small bowel to small bowel intussusceptions can occur in children. And an ileocolic intussusception is the most common type of intussusception in children and requires urgent treatment. Ileocolic intussusception is the most common type in children and requires urgent treatment because it is bowel obstruction. Patients can present with vomiting or decreased appetite, with fewer than 50% of patients presenting with classic triad. So listen, for intussusception, it's a bowel obstruction, so they may be vomiting or decreased appetite. With fewer than 50% of patients presenting with, so about less than 50% of patients present with 3 things. 1, red currant jelly stools, meaning currant jelly stools means that the currant jelly stools means that there is blood mixed with mucus. It's like phlegms that you have mixed blood with. We call it red currant jelly stool. The person will pass through and it will be red currant jelly. Colicky abdominal pain. Colicky abdominal pain. The pain will be there. It will go and then it will come back again. It will relieve you and it will come in short time. Colicky abdominal pain and palpable abdominal mass. Palpable abdominal mass. When we palpate, you see the abdomen may be tensed, it may distend, and we may feel that there is a mass inside. Delay in diagnosis increases morbidity, including bowel ischemia and perforation, as well as mortality. When you delay to diagnose intussusception, the children, they mostly die because the bowel may perforate or rupture and they kill them. So intussusception, we are saying that it has what? A sensitivity of 97.9. That's a sensitivity. And it has a specificity of also 97.8. It has positive predictive value of 86.6 and negative predictive value with 99.7. Under ultrasound, that means that ultrasound is the gold standard for evaluating suspected intussusception. So positive predictive value actually means that it reflects the proportion of subjects with a positive test result who truly have the disease. And the negative predictive value reflects the proportion of subjects with a negative test result who truly do not have the disease. And all of them, it seems that the percentage is very high. And so ultrasound is very accurate in determining intussusception. And intussusception presents as a round mass with a target bowel in bowel appearance in the transverse plane, the classic findings on ultrasound. So before you can write about intussusception, you should see a bowel in bowel appearance. The features are unique in that they consist of concentric rings of bowel wall and internal hyperechoic mesenteric fat. So when you see the mass, you will see that the inside is white, but the outside may be hypoechoic, meaning the concentric rings of bowel will be outside, and the inside will contain what? The fat, which will show white. So lymph node or near the appendix may also be noted within the intussusception. Sometimes lymph node may go into red. The diameter of an ileocolic intussusception can range from 1.4 centimeters to 4 centimeters with a mean diameter of 2.6 centimeters intussusceptions. The pseudo-kidney sign can be seen on longitudinal scans depicted by a thickened intussusceptum bowel wall mimicking a reniform shape. So for the intussusception, sometimes when you take the scan, you may see something like a kidney. In the abdomen, you may see something like a kidney. It means it's a pseudo kidney sign. The reniform, renal shape. It is just a false sign. Where the internal echogenic mesentery of the intussusception representing the central echogenic fat complex of a normal adult kidney. So you see, the sinus of the kidney is white, and the intussusception to the inside is fat, so it is white. So if you don't take care, you may think it is a kidney. Concomitant intraperitoneal free fluid can be seen in greater than 50% of cases. When there is severe intussusception, it will leak some fluid into the peritoneum. Now look at on intussusception on ultrasound. So look at the outer covering. It is hypoechoic, meaning the concentric rings of bowel wall. And the inner covering is the bowel that has entered the intussuscipiens. This is the intussuscipient receiving the intussusceptum. You understand? So intussuscipient is this one. The intussusceptum is the one that is entering it, containing mesenteric fat, hyperechoic compressed loop of bowel telescoping within. And this is the hypoechoic outer loop of bowel, this one. Now the same thing here. So you see, this looks like a kidney. It looks like a kidney, like this is the sinus. But this is the intussusceptum. And the hypoechoic is the intussuscipiens receiving the intussusceptum. So it is, we have it as a target sign. This is a target sign. So you see the inside it is white and outside is hypo. We call it target sign or the do not sign. The pseudo kidney sign is like this. Look at this very clear image. So we need linear probe to capture the appendix and linear probe to capture intussusception. Linear probe, not curvilinear, linear. So you can see the hypoechoic outer concentric rings, which is the bowel wall, and this one has passed here and entered it. And so we can see the inner mesenteric fat. This is intussusception, and this is the intussuscipiens. All of it, we call it intussusception. This one to the target or the do not sign is here, the whitish central part, and then the hypoechoic outer part. So this one, you can see some fluid buildup over here, telling you that the bowels are obstructed. So you can see the entering loop over here. The fat is here, and then the intussuscipiens, there's a hypoechoic here. On longitudinal, you see the bowels like this. You see that the walls are too distant, meaning the bowels are inflamed. The walls are too distant. The bowels are inflamed. So intussuscipiens again, the hypoechoic stuffs over here. That's the intussuscipiens, and the one that is entering is the intussusception. This one to the same thing. Now, clinical diagnosis. Inspection. For visible peristalsis, you have to inspect the abdomen when the person comes. Do physical examination. Inspect the abdomen, whether the abdomen is moving. You can see visible peristalsis, peristaltic activity. Can you see scars? Scars may tell you that the person has undergone a surgery, so it can cause bowel obstruction. Surgery, abdominal distension, and surgery. The obstruction may come from adhesions or development of bands. Adhesions. There will be abdominal distension. Palpation. When you palpate, you may feel some masses. It will be tender. The abdomen will be tender. The patient will guard the abdomen. The patient will tense the abdominal walls, make it hard so that you don't press deep. All the hernia orifices should be palpated to exclude the presence of hernia. When we are treating the scrotal, we will go through the hernia orifices. So, this is herniated bowel, because there is hernia, so the intestines have penetrated into the defect. This is the defect. This is the bowel. This is the abdominal wall, and there was a defect here. So the intestines have passed through the defect and come into the subcutaneous area. So you see that the intestines have permeated. Bowel movement. The doctors or the prescribers can use their stethoscope to listen to the bowel movement. You, the sonographer, can use your probe to check if the bowels are moving. So high or increased bowel movement. So early stages, it will be high. The bowel will move more quickly like that if it is unruptured. When it ruptures, when the bowel ruptures, the bowel will not move again. That is in severe cases. So bowel obstruction proper. Do you see this image? This is the intestine with fluid. We are going to talk about it. Radiographic findings of bowel obstruction can be evident 6 to 12 hours before the onset of clinical symptoms. What we are saying is that even if you are not having the abdominal pain and you go and do X-ray, it will show bowel obstruction before the pain will start. If the bowel obstruction is there, because it will build up before, when the pressure becomes high, then the pain will start. So ultrasound or X-ray can depict it before the pain will even start. Abdominal radiographs are only 50 to 60% sensitive for small bowel obstruction. So ultrasound and X-ray are just averagely sensitive. They are not all that sensitive, but they are helpful. This is small bowel obstruction. Count the dilated bowels. 1, 2, 3, and big one, 4. So these are the dilated bowel loops. Dilated bowel loops. So you have to count them. They have to be 3 or more before you say that there is bowel obstruction. Over here, 1, 2, 3, 4, 5. And there is some fluid here, hunger sign. And this is small bowel obstruction. And the ultrasound, how are we going to know whether there are bowel obstructions? Dilated bowel loops greater than 2.5 centimeters. The 369 rule. Small bowel loops. When it's greater than 3.5 centimeters, then we are thinking of bowel obstruction, but not only that. 3 or more dilated loops of bowel. So you have to count them like this. 1, 2, 3. Once you get 3 or more, then bowel obstruction. Not only that, ineffective peristalsis. So when there is an obstruction and you are doing the scan, you see that the fluid that the person has taken in, you see to and fro movement. The fluid tries to move down, but there is an obstruction, so it will move back, move down, move back, move like that, and to and fro. We call it coiling appearance of intraluminal content. And there could be prominence of the valvular conniventes or the plicae seculae. That's the keyboard sign. I will show you the keyboard sign. When you see the keyboard sign, it shows that the dilatation is in the jejunum. Jejunum. Because the jejunum has a lot of the valvular conniventes. And that shows that there is bowel obstruction, small bowel. Extraluminal free fluid can also be seen. The pointy triangular appearance of the interloop free fluid is often referred to as the Tanga sign. This is transublative mechanism and implies high grade or complete bowel obstruction. Sometimes when you take the scan, you will see that you see this fluid here, fluid build up here, fluid build up here, fluid build up here, and another fluid build up here. But in between this fluid and this fluid, there is a collection of fluid here. This is a Tanga sign. That shows that the bowel obstruction is severe. Tanga sign. Call it pointy triangular fluid. Tanga sign. Extraluminal. Extra meaning it is not in the lumen. It's not inside the intestine, but rather it has leaked out of the intestine because there is complete bowel obstruction, severe one. There will be loss of peristalsis. Loss of peristalsis meaning the intestine will not be moving. It's also a feature. Bowel walls can be greater than 3 mm. When you measure the bowel walls, you get more than 3 mm, showing that the bowels are inflamed. Mural gas, then you see that there is a lot of gas in the bowels. So the first 3 factors give diagnosis for a small bowel obstruction, or first 2 plus any other 2 factors. So the first 3 factors are when you see dilated bowel loops, 3 or more dilated loops of bowel, or the to and fro movement. This 3 only will confirm bowel obstruction, or first 2 and any other one. So you can also pick the first 2 and any other one, like the prominence of the valvular conniventes, or the Tanga sign, or loss of peristalsis or bowel water thickening. You can add it to first 2. It can also what? You can add any 2 to the first 2. Then it means that the obstruction is there. So look at the to and fro movement over here. So it will go up, it will come down, go up, come down, because there is an obstruction. The fluid will go up, come down, go up, and come down. So have you seen these things? The projections in the look at this, please. These projections, the lines, those that look like lines in it, these projections, they are the valvular conniventes or the keyboard sign. When you see it, it means it is jejunal obstruction, small bowel obstruction. They are also called valvular conniventes. Some are here, and it's valvular conniventes. And over here too, you can count 1, 2, 3, 4 bowel obstruction. You can see the keyboard sign or the plicae seculae. Plicae seculae, valvular conniventes, or the keyboard sign. Over here too, we have. Have you seen this is bowel obstruction? This is dilated loop of bowel. This is dilated loop of bowel, and in between it we have what? Tanga sign. This is Tanga sign. In between the dilated loops, we have transublative fluid collection here, which is Tanga sign. Also, another Tanga sign is here. You can see Tanga sign here. Interloop fluid, extraluminal fluid. Kanga sign. Now, other imaging, X-ray is more diagnostic and can easily differentiate small from large bowel obstruction. CT scan is also very helpful. CT scan is also, so in the hospital when they come and we send for scan, the scan says bowel obstruction. The next thing is X-ray. When X-ray confirms it, then we call the surgeon. That is it. So under X-ray, you see X-ray air will look black. Air will look black. On ultrasound, air will look white. But X-ray, air will look black and fluid will look white on X-ray. So air in large bowel, is the large intestine. You can see black stuff inside. That's the X-ray showing gas in the large bowel. That can also tell that there is an obstruction because of the gas buildup. Over here, strength of this sign. So you can see gas and fluid levels, dark and white. So gas and fluid levels, meaning there could be obstruction. Over here, multiple dilated small bowel loop with no air seen in the right colon. So over here too, small bowel dilatation. We can see multiple dilation of the small bowel. And one loop is here, another loop is here, another loop, like that, small bowel dilatation. And over here, air fluid levels. You can see air, you can see fluid, because it looks like dark and it looks like white. That means the air and the fluid is mixed. This is the bladder. You can see that the bladder contains fluid, and the fluid is seen as white on ultrasound. Bladder contains urine. So this is under X-ray. That ends the bowel of the bowel ultrasound. Please, any question? Any question? We are ending here. We will continue from